So welcome all of you to the fourth edition of Vertical Integration session. Today the topic of interest is Ischemic heart disease. We can also call it as coronary heart disease. So literally it is a topic which is close to everyone's heart. To have this discussion, we have eminent faculties from various departments. To start from the right side, Dr. Vidya, she is Assistant Professor in the Department of Pathology. Dr. Vivekanand, he is SR in the Department of General Medicine. We have Dr. Nandita from the Department of Anatomy and Dr. Sanita from the Department of Pharmacology. So we will follow the usual pattern for today's discussion also, covering few important exam relevant headings, and the questions will be directed to a single person and others can chip in as and when needed. So we will start off with anatomy. Doctor, can you just, to start off the session, can you just brief us on coronary circulation and a quick overview of the cardiac anatomy?
Yes, sir. So, heart is a hollow muscular organ which is situated in the middle mediastinum, and it is protected by the thoracic cage, the sternum anteriorly and the costal cartilages laterally. The heart has four chambers, two atria, two ventricles, the right and left atria and the right and left ventricles. Externally, the heart presents an apex which is mainly formed by the left ventricle, and it is lying in the left fifth intercostal space. There is a base which is formed by the right and the left atria, majorly contributed by the left atria, and it has three surfaces: a sternocostal surface which is formed by the right atrium, the right ventricle majorly, and the left auricle and the left ventricle partly. Then there is a diaphragmatic surface which is formed by the right and left ventricle, majorly contributed by the left ventricle, and there is a left surface which is formed by the left auricle and the left ventricle, because the left atrium is obscured by the presence of pulmonary trunk and aorta. So all these chambers are separated from each other by means of grooves or sulci. So between the atrium we have the interatrial groove, and between the ventricle there is, on the sternocostal surface there is an anterior interventricular groove, and on the diaphragmatic surface there is a posterior interventricular groove. Between the atria and the ventricle there is an atrioventricular groove, also called as coronary sulcus. This coronary sulcus has an anterior posterior part and a right and left half. So this is the basic overview of heart. And coming to the coronary circulation, the coronary arteries have some peculiarities. One, it is the largest vasa vasorum of our body, because the heart itself is an endothelial tube formed by the fusion of an endothelial tube. So it is one of those, coronary artery is supplying the heart, so it is one of the major vasa vasorum of our body. Second, it is the only artery that fills during diastole. Then the third point is, these arteries, they are anatomically not end arteries, but functionally they are end arteries, because anatomically, if you see, there are lot of anastomosis between the branches of the coronary artery, but functionally, when it comes to function, these anastomoses are not large enough to provide adequate blood supply to the myocardium in case a large vessel gets obstructed. So when the occlusion is sudden, these arterioles don't get time to these anastomotic channels, they don't get time to open up, so the collateral circulation cannot be established. So there are two coronary arteries, right and left coronary artery. The right coronary artery, it arises from the anterior aortic sinus, which is just a dilatation of the ascending aorta. And this right coronary artery, it passes between the right auricle, which is an outpouching of the right atrium, and the pulmonary trunk. And then it descends vertically downwards, and it travels through the right coronary sulcus, the anterior part. It reaches the inferior border of the heart, winds around the inferior border, and reaches the posterior part of the right coronary sulcus. There it terminates by anastomosing with the continuation of the left coronary artery, which is a circumflex branch. So that is the main course of the right coronary artery. As soon as it reaches the point, that is the crux of the heart, is where the right coronary artery terminates. There it gives off an important branch, which is the posterior interventricular artery. Now, the left coronary artery, it arises from the posterior left aortic sinus. Again, this also passes between the left auricle and the pulmonary trunk, but unlike right coronary artery, the stem of this artery has a very short course, so it immediately divides into its terminal branches, which is the anterior interventricular artery, or the LAD, left anterior descending, and the circumflex branch of the coronary artery. So this left anterior descending, it traverses the anterior interventricular groove, winds around the apex, reaches the posterior interventricular groove, and anastomoses with the posterior interventricular artery. While the circumflex artery, it winds around the left border, reaches the left part of coronary sulcus, and ends there. So this is the basic.
I think that kind of sets the tone for the discussion. But before moving to the next person, is it going to be same in all persons, or is there going to be any difference, or is there any dominance? And
Yes, sir. So there is the dominance depends upon the origin of this posterior interventricular artery. When this artery arises from the right coronary artery, we call it as right dominant. So in 90% of the people, it is right dominant. In 10% of the people, this artery arises from the left coronary artery, but it could be fatal. And in some cases, this posterior interventricular artery can arise from both the arteries. So we call it as co-dominant. That is actually a very good condition.
Okay, got it. So we'll move on to Dr. Vidya. So can you just brief us on the pathophysiology of coronary artery diseases so that?
Yes. So now we have seen the unique and the rich blood supply of heart. Now we'll see what happens, what is the pathology behind the ischemic heart disease. So you know that the heart is richly supplied by two coronaries, and so what happens is the ischemic heart disease occurs when there is a mismatch, or when the demand for the heart is demand of the myocardium, oxygen supply to the myocardium is not met by perfusion by the coronaries. So when there is a disparity between the coronary perfusion and the myocardial demand, the ischemic heart disease occurs. So now why this disparity occurs? It can be due to in 90% of cases, it is due to atherosclerosis of the coronaries. So atherosclerosis or atherosclerotic plaque disease is a chronic disease which occurs over years, in which atherosclerotic plaque is formed inside the vessel. So this will lead to narrowing of the vessel wall, and the cross-sectional area of the vessel is narrowed over time, over years or over months, so that when it is, there is something called a critical stenosis, when more than 70% of this cross-sectional area of the artery is involved or is blocked. What happens is the patient will feel symptoms on exertion, which is called as an exertional angina, exertional chest pain. That is when the stenosis is above 70%. But as you know, it's an ongoing process. So when the stenosis occurs beyond 90%, he can have even angina at rest. So what is the reason for this atherosclerosis? So most importantly, when you come to ischemic heart disease, it's important that you know the pathogenesis of an atherosclerotic plaque, how a plaque is formed inside a vessel like coronaries. So plaques can be formed anywhere, in any vessel, like the iliac arteries, aorta, branches of aorta like coronary, iliac, etc. So we'll see the pathogenesis. In pathogenesis, you know, the word atherosclerosis means there is deposition of fat inside the vessel, which results in the thickening of the vessel wall. So how this fat is getting inside a vessel? You know that the fat is flowing along with the blood cells in the within the vessel through the lumen of the vessel in the form of LDL, that is in the lipoprotein form. So it usually in a normal vessel it flows in that way. But if there is any risk factor, like a person with hypertension, person with uncontrolled diabetes, smokers, in those people, the endothelial, there is an endothelial dysfunction, or the endothelium may get it may get eroded. Normal endothelium gets of the vessel wall, which lines the vessel wall, gets eroded in these people. So that focus acts as a base for the formation of a plaque. So what happens when there is an endothelial dysfunction? As you all know, the platelets and the inflammatory cells flowing in the blood will come and adhere there. So this monocytes, which are the T cell, which are the WBCs present in the blood, they come, and as due to the increased permeability because of endothelial damage, they get inside the vessel wall, and this will turn to tissue macrophage. So monocyte in the blood becomes a macrophage when it comes inside the vessel wall. Now the macrophages from the blood, they get inside the site along with other inflammatory cells. And so what happens is the LDL, which is flowing freely in the blood, they will also get attracted to the site, and they will get inside inside the vessel wall. Now this LDL gets oxidized, and these macrophages, they will eat up these oxidized LDL. So these macrophages now will be filled with this fatty material. So this such a macrophage is called as a foam cell, because FOAM, foam cell, because they have ingested this the fat, the cholesterol. Okay, so as over time, these macrophages or the foam cells increase in number, and the plaque will get bigger and bigger. It can attract other inflammatory cells like the T cells, and then over time what happens is there is smooth muscle proliferation. Smooth muscle cells which are present in the media of the vessel, they proliferate and they come out and they form a cap like thing around this necrotic foam cell center. So, and there is also recruitment of collagen or extracellular matrix. So the smooth muscle cells and the extracellular matrix will form the cap of the plaque, and inside the plaque we get this necrotic center which is formed of the cholesterol and cholesterol esters surrounded by some inflammatory cells. So that is a full formed plaque. So these plaques can aggregate or they join together to form large masses within a vessel so as to cause even partial or even full occlusion of the vessel wall. So that is a pathogenesis of an atherosclerotic plaque. And the structure of a plaque, I have already told you. Inside is a necrotic center around which there is inflammatory cells, and then at the over the top it's an eccentric it's an eccentric structure which is formed inside the vessel wall. So the cap will be protected from the blood flowing inside the vessel lumen by the collagen. Now, so such a plaque is called as a stable plaque which remains in that vessel for a long time. Now, what happens in an MI when there is an acute event like an acute coronary, which is called as an acute coronary syndrome? So what happens is this plaque which is remaining like that for over a long time, which is called as a chronic plaque, it can cause an acute plaque change. That is, I have already told you there is a smooth collagen which lines that plaque. So if there is anything which erodes that collagenous cap, anything which causes a fissure to that, or a hemorrhage within the plaque, or an ulceration of that plaque, that will cause an acute plaque event. That is, the plaque will rupture and the necrotic center, the necrotic products within that center of the plaque will come out into the bloodstream. Those are highly atherogenic substances. So what happens? Suddenly the platelets are recruited there, and that will lead to a huge thrombus formation within the vessel wall, which leads to a complete or almost occlusion of the vessel wall. That can cause to a sudden death or an MI, which is also called as angina, unstable angina, or an MI, or an acute coronary syndrome can lead to the death of the patient. So that is a pathogenesis of MI. So it has got two steps: a chronic plaque disease and an acute plaque change.
Thank you. So we have covered the basics of anatomy and also the pathophysiological mechanisms. To Dr. Sanitha, can you just share some insights on the etiology of ischemic heart disease?
So usually the common risk factors for atherosclerotic disease is like diabetes, hypertension, hypercholesterolemia. So these patients are prone for atherosclerotic plaque, just like ma'am said. So if any plaque with thin fibrin cap, when there is like excision, they are prone for rupture. So when they rupture, there will be platelet aggregation, there will be fibrin deposition, and there will be occlusion of vessel. So depending on the occlusion rate, if it's partial occlusion, it can lead to non-ST elevated MI, or if it's complete occlusion, it can lead to ST elevation MI along with elevated enzymes.
Okay. Dr. Vivek, so what is the classification for ischemic heart disease?
Coming to the classification of ischemic heart disease, we can broadly classify the ischemic heart disease into stable and unstable. Stable ischemic heart disease, where there will be a stable...
On the clinical
clinical aspect. Stable ischemic heart disease, where there is a stable atheromatous plaque which is happening in the coronary vessels, and the patient will be having symptoms of stable angina. While describing angina, the patient will be presenting to our emergency or OPD with classical symptoms of a central retrosternal chest discomfort, mainly during exertion. That's a typical symptom patient presenting with a stable angina. The stable angina patients will be presenting with exertional symptoms mainly. So the patient presenting as a heaviness, they won't be complaining of a pain over the anterior chest. More the symptoms will be heaviness or pressure over the anterior chest wall retrosternally. Usually it is aggravated with exertion, and usually the angina will be crescendo and decrescendo, lasting only for about 2 to 5 minutes. That's a important thing in stable angina, whereas in unstable angina there will be rest angina. Okay, so the basic difference between the classification between stable and unstable is the pain during exertion and rest. We can divide stable angina and unstable angina as the rest pain broadly divided into comes under unstable angina. Okay, coming to the unstable angina, we can classify that as acute coronary syndrome. Where in acute coronary syndrome, we can broadly divide into three categories. One is unstable angina, one is non-ST elevation MI, and other is your ST elevation MI. Okay, the basic differences between unstable angina in STEMI and STEMI is unstable angina, the patients will be having a rest angina. The angina lasting for about more than 20 minutes. There will be other typical symptoms of angina also. There will be associated radiation towards your both arms or ulnar aspect of your forearms and hands, usually associated with autonomic symptoms. Mainly the patient will be having sweating, tachycardia, palpitation and all. So there will be symptoms of vagal stimulation also. The patient will be having symptoms of bradycardia. The patient will be having symptoms of dizziness, syncopal attack also. So majority of the patients need not present with these symptoms. Some patients may present with angina equivalent symptoms. Okay, predominantly they will be having fatigue. They will be having symptoms of diaphoresis. They will be having symptoms of vomiting. So these are considered to us the angina equivalent symptoms, predominantly in elderly patients with long-standing diabetes. So we are aware of that the diabetic patients will be having autonomic dysfunction. So these typical symptoms of angina, which I already explained, central retrosternal chest discomfort, heaviness over the chest or a pressure over the chest, usually it radiates towards both shoulders and arms, usually associated with autonomic features. Okay, so majority of the elderly patients and with uncontrolled diabetes, these patients won't have these symptoms. And these symptoms are considered as angina equivalent symptoms. Okay, so unstable angina patients will be having these symptoms of angina with cardiac enzymes won't be there. So it means that there won't be any myocardial ischemia or myocardial infarction happening in unstable angina. So while coming to the non-ST elevation MI, the patient will be having typical symptoms of angina with the elevation of your cardiac troponins, say as high sensitivity cardiac troponin T and troponin I, as evidenced by other cardiac biomarkers also, by rise in CKMB, LDH and AST. So there will be typical symptoms of angina. There will be may or may not be changes will be in the ECG. So in ST elevation MI, the ECG changes will be, there will be more than 0.5 mm of ST depression, or there will be new onset of T wave inversions. Okay, so these
I think we'll come back to the clinical features this once more. So basically now we have covered the classification and clinical features, right? So as you told, the typical features are there, then some people can come with the typical symptoms also, right? So we'll come back and discuss the investigations in the next question, right? To Dr. Vidya. Dr. Vidya, can you just share some insights on the gross findings usually seen in ischemic heart?
Yeah, gross findings usually seen in the postmortem patients is first, in the first 4 hours there are no gross changes actually, only microscopic changes are there. In the after beyond 4 hours, there is dark mottling which is seen in the heart grossly. So this is because of the blood, extravasated blood and the congestion that occurs. So that's mottling or the reddish blue hue to the infarcted area. And then next, after around 1 to 3 days, then there is an yellow tan center which is due to the coagulative necrosis. So and then over 3 to 7 days, this yellow tan center, it progresses and will lead to a softening of that yellow tan center. And then as a granulation tissue occurs, by 7 to 10 days, there is a border to the yellow tan center, which is depressed. And then after around 4 weeks, there is collagen formation. So that will lead to a gray white scar formation, and beyond 4 weeks it is replaced by the infarct yellow center will be replaced by a whitish scar which starts from the border towards the center of the infarct. So these are the changes that we see. So it takes about around 2 months for the whole gross findings to develop from the infarct to the scar formation.
Okay. To Dr. Nanda, initially we told about the coronary circulation. Now can you just share the thoughts on the blood supply to various parts of the heart?
Yes, sir. So, right coronary artery, the first branch that arises from the right coronary artery is called as conus artery, the right conus artery. It supplies the infundibulum, which is the outflowing part. So, this artery sometimes directly arises from the aortic sinus. In that case, we call it as a third coronary artery. The second type of branches that arise from the right coronary artery is the atrial rami. So it supplies the anterior and posterior surface of the atrium. One of the atrial branches is called as the SA nodal artery, which supplies the SA node, which is a pacemaker of the heart. The next set of branches are called as right anterior ventricular branches. So they supply the anterior, the sternocostal surface of the right ventricle. One of the larger branches of the right anterior ventricular ramus is called as a marginal artery. They are present along the inferior border of the sternocostal surface, and they supply both the ventricles, both the right and the left ventricles. Similarly, it has a posterior ventricular ramus which supplies the diaphragmatic surface of the right ventricle. The major branch of the right coronary artery is the posterior interventricular artery. It supplies the diaphragmatic surface of both the ventricles, 1/3 of the interventricular septum, and it also gives rise to the AV nodal artery. In left coronary artery, since the trunk has a short course, it immediately gives off the terminal branches. So the first terminal branch is the anterior interventricular artery. So this artery supplies the sternocostal surface. There are 3 to 4 in number, and we call them diagonal artery because the this anterior interventricular gives off anterior ventricular ramus, and there are 3 to 4 in number, and we call them diagonal arteries, and they supply the sternocostal wall of the left ventricle. Then it also supplies, it gives a septal rami that supplies 2/3 of the interventricular septum. So the left bundle of His also. And the circumflex artery, one, it gives off a left marginal artery that supplies the left surface of the heart. Two, sometimes this SA nodal artery can arise from the left coronary artery. In 35% of the cases, it can arise from the left coronary artery. Usually they arise from the right coronary. That is the second branch. And the left conus artery, which again anastomoses with the right conus artery from the right coronary artery, and they form an anastomotic necklace around the infundibulum, and it is called as annulus of Viescence. So that is the next branch that arises. So these are the main branches that arises from the left and right coronary artery.
Right. Okay. But to Dr. Vivek, we'll start off from where we stopped. So basically, you are coming to the investigations. So can you just describe the various investigations which are of relevance in ischemic heart disease?
So when a patient initially presents to our emergency department or OPD with a complaints of a chest pain, the first most important investigation which we offer to the patient is electrocardiogram, ECG. So with the ECG, we can very well come to a conclusion that whether the patient is, we need to intervene immediately, or whether the patient is having a stable angina, or whether the patient is having NST elevation MI, or a patient is having a ST elevation MI. So first and foremost investigation, first we need to do in a patient with an angina is electrocardiogram. So in an electrocardiogram, first we can divide the patient into a stable patient and an unstable patient, and with the hemodynamics also. So in the electrocardiogram to diagnose an NST elevation MI, so the typical findings in NST elevation MI is the ST depression of more than 0.5 mm in all the leads with the new onset of T-wave inversions. So in ST elevation MI, the typical findings will be, there will be ST elevation of more than 1 mm in all the leads except for V2 and V3, where the ST elevation should be more than 2 mm. So I will describe the typical findings in a ST elevation MI. There will be a series of events, or there will be dynamic changes happening in the ECG. So first, in a ST elevation MI, the first and foremost things to happen is there will be a hyperacute T wave. So the hyperacute T wave is basically because of the localized hyperkalemia which is going on. So there will be tall and peaked P waves. Okay, that's the first and foremost finding which we will be describing as an hyperacute MI. Then the next change to set in is the ST elevation, J point elevation. There will be J point elevation coming the next, and there will be in the J point elevation there will be the concave. The ST segment is usually concave, so the concavity is usually preserved in the first few minutes. Then there will be ST elevation. There will be the usual concavity of the ST segment is lost. Then there will be convexity of the ST segment. So the next immediate changes will be the ST segment will be overlapping with the T wave. So the next important finding will be there will be QS pattern, and there will be R wave will be the R wave won't be there. So the next important finding, the next hyperdynamic change will be the development of pathological Q waves, and finally there will be T wave inversion. So these are the series of changes which happens in a patient with ST elevation MI. So the important thing which we need to understand is when a patient presenting with an MI, the first changes may not be accurate in the ECG. So we need to repeat the ECG. If a patient presenting with a typical symptoms of angina, and if the initial ECGs are not showing any of the changes, suppose in the initial few minutes of ischemia or infarction, there won't be any changes actually happening in the ECG apart from hyperacute T waves or something. So actually we need to, if the patient is symptomatic and we have a strong degree of suspicion of an acute coronary syndrome, we need to actually repeat the ECG after either a 30 minutes or 1 hour duration, provided the patient should be stable. Okay. So the next important investigation should be the cardiac markers. So cardiac markers basically to differentiate between an unstable angina and a NST elevation MI and a STEMI. So usually the unstable angina, as I already mentioned, these patients will be having typical symptoms of angina with or without ECG changes, and there won't be any rise in cardiac troponins. So usually the cardiac troponins to cardiac markers to occur in the blood will take at least 3 to 6 hours. So it may or may not be positive in the initial blood investigation. So it is an important duty of a consulting or treating physician to repeat the biochemical markers. If you have a high degree of suspicion, you can repeat even after 3 hours of the onset of symptoms. So actually serially we can repeat the cardiac markers after 0, 6 and 12 hours depending upon the symptomatologies. Okay, so with the cardiac, you are all aware of the cardiac biomarkers. One is CKMB, one is high sensitive troponin T and troponin I. The other biomarkers which includes are LDH and AST. So initially the biomarkers will be first to rise is your CKMB and high specific troponin T. The CKMB have a rapid rise and a rapid fall. It will be rising within 0 to 6 hours, and there is a rapid fall after 24 hours to 36 hours, and the levels are undetectable mainly after 36 hours. But troponin 3 levels will be rising initially after 3 hours of any infarction, and it will be remains throughout for at least 2 weeks. So the other biomarkers will be also rising, LDH and AST also. Okay. So the next important investigation which we can offer to the patient is a routine blood investigations. Okay, blood grouping and typing and cross matching if we are planning for the emergency procedures and all. Okay. So all blood routines can be sent, including CBC, RFT, to look for any cardiorenal syndrome, or if the patient has presenting in a state of shock. Depending upon the degree of involvement of your myocardium, the clinical presentation may vary. Some patients may present with only symptoms of angina. Some patients may present in a state of shock, cardiogenic shock. Some patients may present in arrhythmia. Some patients may present with syncopal attack with multi-organ involvement. Okay, so depending upon the situation of the patients, and hemodynamics, the investigations may vary. Okay, so routinely we used to send all these investigations to figure out whether there is any renal involvement or there is any acute ischemic hepatitis. Okay, so if the area of involvement of the myocardium is too extensive, there is in case of extensive anterior wall MI, there will be poor ventricular ejection. So there will be won't be adequate. There won't be any poor renal perfusion leading to acute kidney injury. There will be ischemic hepatitis developing. So all these can be seen only if we send adequate investigations. Okay, so we can send complete blood count, renal function test to look for any acute kidney injury. We can send for liver function test to look for any ischemic hepatitis. Then you can send other inflammatory markers also, CRP and all. Okay. Then in a patient with a stable ischemic heart disease, after taking an ECG, if the patient is his hemodynamic is stable, we can go ahead with stress electrocardiography. Stress electrocardiography is something known as a treadmill test, which we will offer to the patient to accurately diagnose the stable ischemic heart disease or coronary artery disease. So here what we'll be doing is we will be connecting the limb leads towards the hip and the shoulders, and we will ask the patient to we will stress upon the patient. We will ask the patient to run on a treadmill, and we will monitor the heart rate, BP and all. Okay. So what we will be finding is the there will be the significant treadmill test means there are three important findings. One is the positive treadmill test, there will be ST depression of more than 0.5 mm. And there will be, we will be seeing the adequate response of the patient. If there is a fall in blood pressure or if the blood pressure is not adequately raised, we will report the test as positive. And we will see whether the patient is symptomatic, whether the patient is having angina. That can also be considered as the positive TMT test. And the next important investigation is echocardiography. So echocardiography, what are the things we are looking into is, one is the important thing is regional wall motion abnormalities. Okay, depending upon the area of ventricular myocardium involved and ischemia, we will see into the wall motion abnormalities. Okay, and next important thing what we will see in the echocardiogram is the viable new onset of ischemic myocardium or viable myocardium. Then the next important thing is in the echo is left ventricular ejection fraction. So as I already mentioned, depending upon the involvement of the myocardium and the involvement of the vessel involved, if in a case of extensive anterior MA and all, the ejection fraction will be very much reduced. So echocardiogram is inevitable in assessing the functional capacity of the patient. One is the left ventricular EF, other is to see the wall motion abnormalities, and other is to see the new onset of any infarcted myocardium. So there are various other investigations which we can offer the patient in a stable coronary artery disease, such as multi-sector, the CT scanning to look for any coronary calcium deposition. And for now it is very important in most patients what we can offer in case of patients with angina with a lower degree of suspicion of the disease. Suppose if a patient with symptoms of angina presenting with in a younger age with no family history, and if the likelihood of disease is very low, we need not go for immediately for a coronary angiography. So we can offer the patient, such patients as CT scanning, CT angiogram to look for the coronary artery diseases. So in the other investigations which will be done in higher centers are myocardial perfusion scanning to look for the viability of the myocardium. That can be done in two different scenarios. One is the patient will be the perfusion scanning will be done at rest and will be seeing the viability of the myocardium, and then stress perfusion scanning. We will be asked the patient to do some exercise, and then we will be doing the perfusion scanning. And if there is a perfusion defect, it indicates that the patient has a coronary artery disease. Then other investigations includes coronary catheterization. That is the most important thing in a patient to diagnose a coronary artery disease. It's an invasive procedure where a guide wire is passed into the coronary vessels, and we see the coronary vessels actually, and we will quantify the disease actually. So these investigations are very inevitable in a patient's presenting to in a emergency department with acute coronary syndrome. Usually there is a something known as golden hours, 4 to 6 hours. With the patient presents with a 4 to 6 hours of symptom onset, and we diagnose the patient clinically, and we have evidence of myocardial ischemia and infarction with biomarkers with positive clinical findings. We can immediately take the patient to the cath lab and we can do catheterization followed by the definitive procedure, either a PCA or this thing. So that will be the investigatory things.
Yeah. So basically we have the ECG, we have various blood investigations, and also various imaging tools. And again, this can be, the pathway can vary from whether the presentation is acute or we are working up more like a chronic chest pain kind of scenario. Okay, thank you, Dr. Vivek. Moving to Dr. Sanitha. Sanitha, can you just give us some details about the various drugs which are used for management of ACS?
So these patients, when they present with anginal pain, the drug of choice, that is vasodilator, we give nitroglycerin. So nitroglycerin, it will reduce the preload on the heart, so thereby it will reduce the anginal pain. If the patient has vasospastic angina or princemetal angina, then nitroglycerin is ideal because it causes dilatation of coronaries. And other drugs which we can give is beta blockers and calcium channel blockers. But one thing we have to remember is beta blockers is contraindicated in vasospastic angina because it will exacerbate the anginal pain. Other than the vasodilators, the patient will have pain, so we have to relieve the pain. So ideally, we prefer opioids, that is morphine, that will relieve the pain. The advantage of morphine, it will allay anxiety and apprehension that which can produce tachycardia in patients, and also it relieves the pulmonary edema due to peripheral vasodilation. Then in acute coronary syndromes, there is platelet aggregation, so we have to target platelets aggregation. So we have to give antiplatelet drugs, that is aspirin, clopidogrel. Then to target the clotting factors, we have to give anticoagulants, that is heparin, then LMWH, or once a patient is, along with that, we can give oral anticoagulants like warfarin. Then if the patient presents with pump failure, we can give inotropic agents like dobutamine, dopamine, or diuretics like furosemide. Then if the patients present within 6 hours, we can give thrombolytic therapy. So that is streptokinase, which is outdated. Now we have tenecteplase, reteplase. So the advantage of tenecteplase, we can give during the transport itself, because it can be given easily. Within 10 seconds, we can give single bolus shot. Then
So definitely we are going to give an anti-anginal agent. We are definitely going to load the patient with antiplatelets, and also in centers where we don't have a facility for angioplasty, definitely thrombolytic agents will also come into the picture. Fine. Over to Dr. Vivek. Dr. Sanita mentioned about the pharmacological aspects of management.
Yes.
So, but again, if you look at the management, there are certain non-pharmacological
Yes.
aspects also. If you can just detail us on the non-pharmacological management.
Definitely, sir. So when a patient presenting with an acute coronary syndrome, the patients may or may not be stable. Okay, first we need to assess the hemodynamics of the patient. So first we need to stabilize the patient before taking any procedure. So Madam I already briefed about what are the initial managements which we should be doing in a patient with an ACS. So first and foremost thing is the stability of the patient. If the patient is unstable, first try to stabilize the patient with, if the patient is in a state of shock, we need to give inotropes. We need to stabilize the patient first. Then if the patient presented within a 4 to 6 hours of the symptom onset, we can directly take up the patient for the rescue PCI. So rescue PCI, for what we will be doing is we will be passing a guide wire into the, we will be putting a guide wire into the coronary circulation, and first we will use a balloon. With a balloon we will actually dilate the stenosed coronaries. So the coronaries will be actually dilated. So we can't dilate more with the balloon. So with the available options, we will be using a stent to actually we will deploy the stent in the stenosed segment, and we will dilate it in a maximum level, so that the risk of restenosis is actually low. So there are multiple options which various cardiologists usually practice. They will be doing thrombosuctioning, liposuctioning they will be doing. They will be doing only balloon dilatation. It's depending upon the individual preferences. So usually we will be doing a rescue PCI. So we will identify the culprit vessel. First we will do a coronary angiography. So we will see the culprit vessel, and finally we will do a balloon dilatation, and finally we will do a angioplasty. Angioplasty means we will dilate the stenosed vessel with a stent. So there are various options we have now. So we will be using a drug-eluting stents now. Okay. So Madam already briefed us. There will be smooth muscle proliferation which is happening in the pathogenic processes. So if we put a stent simply, the risk of restenosis of stent is more common. So usually the risk of restent thrombus is common within 3 months of this procedure. So we'll be using drugs such as drug-eluting stents, such as sirolimus or paclitaxel, which will be eluted slowly from the stent into the system, preventing the further smooth muscle proliferation and further thrombus. So the major advantages of this is this procedure is so we will be having saving the myocardium. So once you all aware that once the myocardium is infarcted, so it can't be salvaged. So the time is over. So we need to intervene immediately. So whenever a patient presents you with a chest pain, first take a ECG, figure it out whether it is an acute coronary syndrome or not. If it is an ACS, immediately take the patient to a cath lab and do a coronary angiography and rescue PCI. If the center has a good cath lab and availability of cardiologist, or the routine management can be done if the center is not there. So the complications expected in this procedure is usually the stent thrombosis. It can happen at within 3 months. So after 3 months, the likelihood of stent thrombosis is less common. So other important complications which we can expect is during the procedure, the thrombus can migrate and it can get dislodged into the other vessel and can cause MI. So it is considered as a type 4 myocardial infarction. And other important complication is coronary dissection. That is one of the important cause which can also cause myocardial infarction. So these can be tackled at the further interventions. So one of the most important aspect is coronary this angioplasty. Then the other important option is coronary artery bypass grafting. So for the bypass grafting, the stability of the patient is very important. So we can't take the patient for the coronary artery bypass grafting as such. So good important option is only primary angioplasty, and it can be done only in a single or a 2 vessel disease. If the disease is more than 2 or it involves multi-vessel, the good option will be CABG. So usually in an unstable patients, doing a CABG is very risky and it's a high risk this thing. So usually in a CABG can be done in an elective basis. So in a patients with a stable disease, we have done a coronary angiography, and if we see if a complex or a more diffuse disease is involved, or if the vessels involved is 2 or more, we can offer the patient a CABG. Because multi-muscle PCA is too risky, and the risk of stenosis and the risk of patient developing angina in future is more. So for these patients, selected patients will be taking up for coronary artery bypass grafting. So in CABG, the most commonly used vessels to graft is internal mammary artery, radial artery, or the reformed saphenous grafting also used. So in usually in a arterial grafting, the risk of future thrombus formation is low. So most of the cardiovascular thoracic surgeons will be using complete arterial grafting only. So there are 2 techniques of the on-beating surgery, and there is something known as coronary artery bypass. Okay, so usually nowadays these grafting can be done in on-beating surgery also, and the most common complications which are expected is coronary artery graft rejection. Graft can be rejected because of technical issues, or the distal runoff is poor because of the diffuse disease. So the chance of a patient getting this graft thrombus is also more in patients, in elderly patients, and patients who have a chance of diffuse disease. So these patients should be put on a lifelong antiplatelets, dual antiplatelets initially, and a single antiplatelet subsequently. So this patient after procedure, the neurological complications is also more. The chance of patient developing cerebrovascular accident is also more. 1 to 5% of patients have a risk of developing neurovascular complications, especially stroke. So these are the 2 important non-pharmacological treatment available, and as all we know, in a patient with a stable angina, apart from the medications, lifestyle modification is also very important. Lifestyle modification in the sense we will be doing a routine physical activities for at least 20 minutes per day, at least for 3 times a week. Okay, and dietary habits should be modified. We should not use more than 10% of saturated fat, and we'll include more polyunsaturated fatty acids. If the patient is having a habit of smoking and alcohol, ask him to cassette smoking and alcohol, because all these will influence further disease progression and the development of angina and further symptoms. So basically the treatment will be lifestyle modification, pharmacological therapy, and finally non-pharmacological therapy, including angioplasty and coronary artery bypass grafting.
Thank you, Dr. Big. Dr. Vidya. So we did talk about the gross features. Can you just tell something about the microscopic features?
Yes. Microscopic features, actually they developed after half an hour of the infarct. So basically it is myocardial death due to the absent blood supply to the myocardium. So, when the type of necrosis which occurs whenever there is an absent blood supply is the coagulative necrosis. So, it is coagulative necrosis of the myocardial fibers which occurs in MI. So, the first change that we see is the extravasation of blood and congestion, and then the next, after 1 to 3 days, you get the, in 12 to 24 hours, you get the early coagulative necrosis which starts, and then a coagulative necrosis sets in by 3 days. After that, there is a neutrophil infiltration, because this necrotic center will act as a, it will recruit the inflammatory cells. It's an inflammatory focus, so the neutrophils come there. And then there is the myofibrils or the myocyte fibers will degrade. Neutrophils will also degrade, leading to the necrotic debris there. So now the necrotic debris and the myocyte fibers, fiber debris, they are all cleaned up by the macrophages, and then comes the onset of the granulation tissue within first 2 weeks. The granulation tissue is a well-formed granulation tissue which starts from the border of the infarct towards the center, and finally by 2 months we see the collagen scar tissue. Microscopy, we see it as collagen. So these are the microscopic findings according to the age of the infarct.
Okay. So just we'll come back to the pharmacological aspects. Initially, we already told that during the acute management, we definitely give the patient an anti-anginal agent, and then there is this concept of loading dose, right? So in the loading dose, we usually give an aspirin loading dose of around 325 mg. We give clopidogrel, or it can be replaced with clopidogrel 300 mg or ticagrelol of 120 mg or prasugrel, depending upon what pathway the patient is taking, right? If the patient is going into the thrombolytic pathway, or the patient is going into the PCI, your drugs can kind of be modified, and along with that you give a loading dose of statins also. So that is with the emergency kind of management which we touched upon. There is also this concept of remodeling of heart, right? If you can just share your thoughts on this concept and what is it?
So if the heart remodels, the problem is it can go for cardiac failure at a later stage. So what we have to do, we have to give drugs which prevent remodeling. So there are certain mediators like adrenaline, noradrenaline, then there is angiotensin, aldosterone. These hormones are responsible for the remodeling of heart. They basically act on the cyclic AMP pathway and stimulates the MAP kinases enzyme, which later lead to remodeling of heart. So if we use beta blockers, AC inhibitors, ARBs, then renin antagonist, it will prevent the mortality in these patients, and also it will prevent the remodeling in heart.
Okay, right. With that, all pre-prepared questions are over. The last question to each one of you. So, in this topic of ischemic heart disease, what are the questions which a student can expect in the exams?
So, pharmacological viewpoint, the most it's a management of myocardial infarction. That is a emergency management of a myocardial infarction. The student should be prepared of. Then they can expect short notes, AC inhibitors, then nitroglycerin mechanism of action. They can expect a short note. Then the rational question, why beta blockers should not be combined with verapamil or diltiazem, that they can expect.
Okay. From the anatomy perspective?
So the origin, course, branches and the distribution of pattern of the coronary artery can be an essay, sir.
Okay.
And coronary dominance can be asked as a short note, and the arterial supply of the conductive system, SA node, AV node, bundle of His, that can be also asked as a short note.
Okay, so we have covered the questions here.
Yeah.
Right. Vivek?
Mainly acute coronary syndrome, sir. It can be asked as an essay also.
Okay.
Acute coronary syndrome, how to diagnose acute coronary syndrome, how to, what are the ECG changes in acute coronary syndrome, initial management, and finally the definite management of ACS. The clinical features to know basically the clinical thing.
Okay.
That's all. Fine.
from pathology perspective?
In pathology, it's usually asked as a modified essay question with a clinical scenario of the patient coming with retrosternal chest pain, and ECG findings will be given and the cardiac markers will also be given with the sub-questions. Sub-questions usually ask you expected to learn the pathogenesis of atherosclerosis. Then you may be also asked to draw an atherosclerotic plaque. Then other questions, definitely if MI comes as an essay, you'll be asked to write the gross and the microscopic findings according to the age of the infarct. In short answer, again, atherosclerotic plaque, to draw and label an atherosclerotic plaque.
Okay, so thank you all, and hope all of you had a good session, and there was definitely something for all of you to learn. Thank you.